Chapter 26. Chapter 26 is the hematologic disorders. Hematology has to do with blood. Oftentimes also gets lumped in with actually oncology, or at least considered to be with oncology in many cases, because hematology has to do with disorders of the blood, and many of the different types of blood disorders, particularly white blood cell disorders, are cancerous. So leukemia, lymphoma, multiple myeloma, those are a couple of named primary examples there. With hematology, we're really more specifically looking at the blood, but like I said, a lot of times they kind of group them together, and you may even have hematology oncology specialists that kind of look at both systems. But specifically it is the blood. So as with all of our chapters, simply listening or watching the lecture is no replacement for reading and studying the chapter, so do so at your earliest convenience. The education standard that applies here is that you'll be able to apply fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for an acutely ill patient. There's a multimedia video for sickle cell anemia. You have a handful or two of objectives on page 651 and 652, so we'll slip through those. So introduction, hematology, like I said, is the study of blood and blood-forming organs, or what is often referred to as hemopoietic. So hemopoietic. And the disorders related to the red cells, the white cells, the platelets, and coagulation are those that are particularly of importance to hematologists. All right, so blood, as we recall, 55% of blood is roughly plasma, and 92% of blood plasma is water, so about 8% other formed elements, proteins, and so on and so forth. Then, of course, we have the formed elements of the blood. What I just previously said, formed elements, please don't take that to mean the same thing. Formed elements would be things like, occasionally we have some, obviously, dextrose in there, so on and so forth. So that the actual formed elements that pertain to blood are the erythrocytes, or red blood cells. That's the appropriate abbreviation there, RBCs. The leukocytes, or white blood cells, WBCs, and then the thrombocytes, or platelets. So that is the rough and the significant portion of those is the erythrocytes. So most of it, and I think if we can recall back to, let's see, cardiology. I believe cardiology, we looked a little closer at blood. But the average adult human has somewhere between 5 and 6 liters of blood. Obviously, that's going to depend mostly on body size. So if you're 6'6" and 300 pounds, you better plan on having 6+ liters. Whereas if you're 5'2" and $120 all soaking wet, you probably have closer to 5. All right, so the liver, the spleen, the bone marrow are all responsible really for the maintenance of our blood. They'll clean out the old cells, the damaged cells, and try to get those dumped so they can either be recycled, in the case of like platelets are actually recycled red blood cells. Or they're just eliminated altogether and then gotten rid of through the various processes in the body. The bone marrow is primarily responsible for creating new cells. The spleen is really kind of a blood bank or storage facility. The liver also acts as basically a storage center as well, simply for the fact that it is so very vascular. It has so much blood going through it at any one time. Not to mention it's almost like a sponge. So, but bone marrow is primarily responsible for creating the new. The kidneys and the liver secrete hormones that stimulate red blood cell production. That hormone is erythropoietin. If any of you know anybody who's undergone treatment for a couple of the different blood cancers, you may have heard of them being on erythropoietin. I think another name for this is Procrit, and sometimes it's referred to as simply epoetin. And what this does is it tells the body, hey, we're getting a little low on our transport system here. We need you to add some more players here. So let's create some more red cells. The plasma, in turn, is protein-based. This is a colloid solution. So if we go way back to when we were talking about meds and isotonic crystalloids and whatnot, the part of this that was called colloidal solutions is plasma is the ultimate colloid because it does carry the red cells as well as the remaining formed elements of the blood. But it is essentially albumin, has some clotting factors, some antibodies, and then there's those things, like I said, electrolytes, medications, nutrients, hormones, other things that can be found within it. Again, another good simulation for blood plasma. If you crack an egg and take a look at the egg white, that's a pretty close replacement then for plasma. So to kind of sum that back up, colloids are protein-based liquids or fluids, and crystalloids are generally a element or salt or a compound-based substance that it can be produced artificially. Not that colloids aren't, but things like salt water, sugar water, that are crystalloids. Okay, so kind of how does this whole hypoxia, or how can hypoxia trigger the release of epoetin? Shows us there that the kidney will start to detect tissue oxygen levels declining. Remember, you've got all these sensors everywhere. You have chemoreceptors and baroreceptors, and those chemoreceptors are looking for specific elements, baroreceptors, the pressures that they provide. When the kidney starts to see a decrease in oxygen levels, it releases the EPO, or the epoetin. And what that does is it causes in the bone marrow the stem cells to increase their division rate. Remember that cells in our body are created through division. So when we need more cells, a mature cell splits in two, becomes two new cells. So and then it also accelerates their maturation. So we have erythroblasts, and those erythroblasts are immature red cells, and it does take some time for them to mature in most cases, a couple of days in most cases to kind of get to a full maturity. However, they only have a limited lifespan of around 120 days, so it accelerates them maturing a little bit, turns into reticulocytes, and then those reticulocytes mature into the full active red blood cells. So therefore we have an increase in the number of circulating RBCs and improved oxygen content of the blood, and then the tissue oxygen levels rise. I want to make you think about this for just a second here. So when our body detects low levels of oxygen, it pumps out epoetin, creates more red cells, so we have tons of red cells running around the body of the person who is hypoxic. Think back to the respiratory chapter. Who did we call the pink puffer? The pink puffer was the specific COPD patient that has emphysema. Emphysema patients constantly ran on low oxygen levels in their body because they were usually smokers, and that low levels of oxygen in their body created that hypoxia in the kidney. The kidney says, well, that just isn't going to do. We need more red cells. So it just constantly pumped out EPO, and that EPO created lots and lots and lots of red cells, and therefore gives them the pink skin tone. So our red cells are flattened discs, thicker on the edges, thinner in the center. I like to think of them as, at least when I was in the later stages of my childhood, they came out with tractor tire inner tubes with a little membrane across the middle, and it was, your sledding disc. So it wasn't a hole in the middle. It was that kind of membrane across there. I like to think about red cells like that. I think they probably do those a lot for tubing now as well, for behind boats and whatnot. But the red cells kind of have that hollowed out center and then thicker edges. They don't have a nucleus. They provide a greater surface area for gas exchange, and it makes them flexible to squeeze through the capillaries. I've mentioned in the past, I think it was also cardiology, that occasionally the capillaries are so small that the red cells actually have to bend in half in order to make their way through. And these are manufactured from the stem cells in the bone marrow. So we've talked about that, and we've mentioned that the bone marrow is a critical place. You can see where people with bone marrow issues really could have some significant issues with their production of blood. So if we wipe that out, whether we wipe it out with chemotherapy, the cancer wipes it out, whatever, it really puts the patient at a huge disadvantage. So furthermore, we have a couple of other, I mentioned lifespan was 120 days. Epoetin increases to stimulate the bone marrow to increase red blood cells. And then we have the concepts of hematocrit and hemoglobin. We've talked about these both briefly in the past, so we'll take just another moment to talk a little bit about this. So we mentioned, and this is going to be on page 653, it's the bottom of the words of the second column right above the picture, and then the top of the second column on that. Hematocrit is the measure of the percentage of blood volume that is composed of formed elements, the majority of which are RBCs. So on average, a blood count, blood is about 45% of formed elements, with a higher normal level in males. So in males, we typically consider a hematocrit of 40 to 52% to be normal, and in females is slightly lower at 35 to 47%, so about 5% lower than the males. So that amount, the amount of hemoglobin, which is the iron-containing protein that carries our oxygen and some of the carbon dioxide within the red cells, is important as well. So if we have an anemia, anemia is going to show up actually potentially in one or both of these elements. If we have a small amount of red cells and formed elements floating around, you can be anemic, yet those can be very healthy red cells in which the hemoglobin is probably going to be fine. Or we could have a normal level or even a high level of red cells floating around in there. However, they're iron deficient red cells, or let's say sickle cells that can't carry oxygen well. And even though the number of red cells or the percentage, the hematocrit, is normal, the hemoglobin may be very low. So therefore, they're still anemic. Or you could have both be bad. Low levels of formed elements in the blood and low amounts of hemoglobin on those red cells. So those are a couple of things that could potentially cause anemia. So back to hemoglobin for just a moment. The amount of hemoglobin that we find on those red cells is measured in grams per deciliter, and basically the same as we do, or actually this is slightly different than we do for dextrose, because we're looking at milligrams per deciliter. But in grams per deciliter, we have 14 to 17.4 for males, 12.3 to 15.3 in females as their normal amount of hemoglobin. So it's kind of heavy stuff in the grand scheme of things, but remember it is composed of iron. So. And then it kind of goes on to talk a little bit more about the red cells further down in this paragraph here. The way that hemoglobin molecules bind on the red cells, it will allow up to 4 oxygen molecules per hemoglobin. Okay. And there are millions and millions and millions of these on each on each red cell. All right. So, and that's kind of what gives it its reddish color is when the molecule is fully saturated with oxygen, it brightens it because of the oxygenation. What color is desaturated hemoglobin? Many people think it's blue. It's not. It's red. It's a dark red. It's more of a maroonish color as opposed to a scarlet color. It looks blue because of the darkness of the vessel and how much of it is visible through the thinner parts of the skin, but it's actually a darker red. And then white cells. So we have white blood cells. These are the very tiny fraction. We talked about this also last week, and when we looked at the differential of the different types of white cells, and which it mentions there, neutrophils, eosinophils, basophils, monocytes, and lymphocytes. These get signaled by various chemical messengers. Sometimes it's hormones or other things that will tell them to travel where they're needed. The different types of white cells respond differently to different types of antigens. So I mentioned that before, that some of them really probably work a little more on viruses, some of them work more primarily with bacteria, some of them may be parasitic items, some of them actually in allergic reactions play a big part. So some of them are very non-specific. They'll respond really to inflammation and injury. So monocytes, neutrophils, and eosinophils. So monocytes, neutrophils, and eosinophils can ingest material through a process called phagocytosis. So those specific cells respond, and they'll just try to wrap themselves around whatever it is and try to neutralize it or take it out there. So phagocytosis, going way back when we talked about this before, phagocytosis is a cell eating. So it's that cell gobbling up something else, trying to knock it out. Lymphocytes, or B lymphocytes and T lymphocytes, we have 2 really different types. We have some of the lymphocytes that come from blood, i.e. B, and T lymphocytes, which come generally from your thymus gland, which is above your heart there. Remember, it's the only part of your body that really gets smaller as you age in the grand scheme of things. So are involved in specific immunities and to very certain types of antibodies. Mast cells, talks about mast cells a little bit in this part as well. And the mast cells are basophils, and those mast cells migrate into the tissues and they start to release histamine and heparin. Well, we know histamine comes along with allergic reactions. Heparin is kind of a good buddy of histamine, so it comes along to help destroy stuff and break it down. So when we have somebody who's having anaphylaxis, we have a significant number of basophils that have come in there and started basically belching out their acids, and that's kind of what they do, is they're kind of filled with acids to spill on stuff and try to wipe it away and break it down. And we also see macrophage come up from time to time. Now, it's not listed on here. Macrophage is not listed on here, but macrophage is a monocyte, a very specific monocyte. It's migrated into certain tissues, and it works to engulf those pathogens and any cellular debris. Microphages, on the other hand, are fixed. They locate in very specific tissues such as the lung, the liver, and the spleen, and they work to clean up things from that area all the time. So now we're going to talk a little bit about platelets. This picture is on 654 in your text. talk about platelets and the clotting factor and the clotting cascade and how our body responds to bleeding. So platelets are fragments of thrombocytes, which exist really only in the bone marrow. They're actually generally just made by recycling other cells, and they're activated by exposing tissue collagen to the injured blood vessels. So when the tissue collagen, so let's say the inner lining of our blood vessel, comes in actual contact with the red cell, then that actually causes a chemical message to be sent. As long as there's the slick inner layer of the vessel in place, it separates them, and so it doesn't cause this to occur. When they're attracted to this injured area, they become very sticky, adhere to the injured tissue, and then begin to agglutinate or clump together with each other, also called platelet aggregation, and it causes this plug to form. The plug itself is a temporary band-aid while the remaining cascade comes into play. So that remaining cascade we can see is pictured here on the slide or in your textbook. We have a couple of things that occur. We have the extrinsic pathway and the intrinsic pathway. The extrinsic pathway, we have tissue damage, starts to cause platelets to aggregate. Then those chemicals, as they start to aggregate, kind of build up, and they then will start to activate the common pathway, in which the prothrombin activator comes into play. It plays with calcium, Ca++, remember it's calcium. That's going to activate some different hormones of prothrombin and then convert that into thrombin. And then thrombin will also combine with calcium, and it will activate fibrinogen, which converts it into a fibrin clot or traps more platelets. So basically what happens here, all in all becomes fibrin. What we're going to be looking for eventually is fibrinolysis, but all in all, what's basically happening here is if we have the extrinsic pathway, we get the same route from the intrinsic, whether we have platelet damage, and then when the platelets become damaged because maybe they're getting flushed or brushed or beat up, then the platelet aggregation and then the chemical mediators. But what I'm getting at is ultimately through the process of a couple of changes in hormones and a couple of changes in some of the consistencies of the clot, we then build up a fibrous band, and that's where we kind of see fibrinogen coming from there. As these bands kind of start to tie everything up, almost like baling twine or baling wire, that helps kind of puts this whole thing together and cinches it up. So there's a lot of factors that go into this, and as we look at the little section on hemostasis, we're going to see a few more other things that kind of come into play with hemostasis. We have a couple of significant players in the game, such as vitamin K, calcium and vitamin K, and they help create this fibrinogen, which creates the fibrin portion. The fibrin is the actual bands themselves. It mentions in here also that the normal clotting process occurs locally, just at the area of injury. However, when we have a severe injury or we're losing blood at a very rapid pace, it causes a systemic formation of blood clots. And this is kind of counterintuitive to what a lot of people think about, is if we're losing lots and lots and lots of blood, your body actually kind of slams into emergency clot mode, and it creates millions and millions of microclots, itty-bitty tiny clots. Unfortunately, it takes away from the area that really needs those clotting factors, so the bleeding just continues. So that process of making these millions and millions of microclots is called disseminated intravascular coagulation, or sometimes also referred to as disseminated intravascular coagulopathy. But this in turn takes up everything there and just keeps it from doing the job it really needs to be doing. And these people generally bleed out. This is, has a very high mortality rate once people go into DIC. And then deficiencies in certainly parts of your diet, particularly vitamin K and calcium, can really give you some overall deficiencies in your ability to clot. So, and then there's of course the branch of bleeding disorders that we look at is called hemophilia, which that's we'll get to here in a little bit. So this basically just goes through and discusses what I kind of chatted with you about there. Now, the last part of that green picture actually talked about fibrinolysis. And that fibrinolysis occurs usually later after the healing process has occurred. I don't like the way, in particular, that they put it in that chart because it makes it look like it happens immediately. But the fibrinolysis then goes in. The body creates something called plasminogen activator, which goes in and creates plasmin, and that plasmin then starts to dismantle the clot or take the clot back apart because it's no longer needed. Well, sometimes we give the patient a form of plasminogen activator, tissue plasminogen activator, which is TPA, and TPA, if you remember from stroke, TPA is the drug of choice for treating people with an ischemic stroke. So when a blood clot is formed, we should also give that drug, particularly TPA, to heart attack victims who had a clot. We have a refined version of it now that's called TNK, which is tenecteplase. It is a form of a tissue plasminogen activator, and that's what currently is the drug of choice for most heart patients. All right, so hemostasis. That is the process of stopping bleeding. That injured vessel is going to start to constrict. We know this from talking about, say, the hemorrhagic shock chapter or portion of the shock chapter. So we get some constriction of the vessel, trying to slow the blood flow. Platelets are going to be attracted to that area and form their platelet plug. They're going to start to activate the appropriate pathway, which is probably the extrinsic pathway. And that extrinsic pathway will then start the cascade, really, of the different hormones. The prothrombin activator creates the thrombin. The thrombin then creates the fibrinogen, which then in turn becomes fibrin. All of that in the presence of calcium in most cases. Coagulation is the formation of a stable blood clot. Agglutination is the process of them getting together and kind of starting to build a clot. Coagulation is the official clotting or the stopping of that bleeding. And we mentioned DIC before, the systemic blood clots. Just a couple of common medications that can affect hematologic disorders. So alfalfa would be used in more of the holistic medicine world. It gets used really for arthritis. However, it contains coumarin and vitamin K, and that excessive use interferes with anticoagulant drug therapy. So with lots and lots of vitamin K, you're more prone to build clots. Aspirin, most people are on aspirin that are older and have risk of cardiovascular disease. It is an anti-inflammatory, it's an analgesic, platelet aggregation inhibitor, obviously one of your drugs that you can carry. It increases bleeding from impaired platelet function. So basically it takes some of the sticky off the platelets. And so if the platelets aren't quite as sticky, they're not as likely to clump. Borage oil, again, used as an anti-inflammatory. And you'll see a lot of these are really anti-inflammatory. Remember, arthritis is an inflammation. It prolongs bleeding times. Clopidogrel or Plavix, very, very commonly used drug these days. It's a platelet aggregation inhibitor as well. It's kind of like super aspirin, except just in the platelet world. Going to cause them to bleed more. Dong Quai, this is a holistic medication. It's Asian herb that's used for PMS of all things, and contains coumarins as well, and can interact with warfarin, increases the bleeding risk. Feverfew, this is another holistic medication for the treatment of migraines, has antiplatelet and anticoagulant effects. A lot of these things are really kind of reducing viscosity of blood, making the blood thinner, therefore hopefully reducing some of that inflammation. Garlic, for concentration, is also another anti-inflammatory. It is a commonly used anti-infective, at least in the holistic world. It's said to also decrease the risk of heart disease. It also increases bleeding times and decreases platelet aggregation. Ginger, another anti-inflammatory, anti-nausea, and analgesic substance, decreases platelet aggregation. So I think you're kind of getting it, that for the most part, most of these things make you bleed longer. Ginkgo biloba, used very, very commonly. It's supposed to improve mental clarity. Guarana, most of you guys, if you guys are into the energy drink worlds, all of your Red Bulls and whatnot usually have guarana in it. It can help, or it can inhibit platelet aggregation. Horse chestnut, it's used for varicose veins, causes increased risk of bleeding. NSAIDs, ibuprofen, naproxen, ketoprofen, irritates the GI tract, and it inhibits platelets. Turmeric, used to treat arthritis, has an antiplatelet effect. Vitamin E is an antioxidant. It inhibits platelet aggregation. Vitamin K, which we usually get from our green leafies, can block the effects of heparin and warfarin, so it actually causes more likely to cause clots. So it's kind of a 180 from the theme we've been seeing. Warfarin or coumadin, it's an anticoagulant. And then white willow bark. White willow bark is actually where they started to isolate the properties for aspirin from, acetylsalicylic acid, or the salicylate. In fact, the Native Americans used to chew on the white willow bark when they would have pain and discomfort, and that would help them. So, and it can inhibit the platelet aggregation as well. There are more and more and more things out there. One I just recently saw, Eliquis. Eliquis was a big one. There's a couple of other ones that this is kind of a big money maker for the drug companies. But some of them have become a little bit dangerous, actually. And the drug that I'm thinking of, we'll look it up real quick, but it actually can cause you to bleed and bleed and bleed, and cause you to bleed and bleed and bleed, and then not be able to clot. It becomes extremely dangerous in many cases because some of these newer drugs, they've been pretty defined. Pradaxa is what I was thinking, which is dabigatran. There's a couple of other ones out. Xarelto is another one I've seen lately. It's rivaroxaban. But Pradaxa predominantly is the one that we've heard some horror stories in which people suffered trauma, were on Pradaxa, and basically bled to death because they were unable to control the bleeding from this person. So, of course, we have blood groups, blood typing. Many of you probably know what your blood type is. If anybody's given blood, you certainly should know. We have lots and lots and lots of different antigens in our body, in our blood. But the two biggest, most commonly referred to ones are the ABO system and the Rh system. Those are probably, in the cases of emergent setting, probably the ones that we're really the most concerned with, because if somebody needs a transfusion, by knowing the ABO system and their RH factor, then we can usually get them an appropriate type of blood for transfusion. All right, so A, B, both A and B, and no or 0 O antigens can be on somebody's blood. So if you want to look at 656 in your text, so we'll say if you're a type A blood, your surface antigen is A, so your body will fight B. It creates anti-B antibodies. So if B blood is then introduced into your body will attack it and start to destroy it. It's basically 180 degrees when you're talking type B. They have the surface antigen type B, but their body creates anti-A antibodies, so your body's ready to fight off any A that would come in. If you happen to be type AB, you have both A and B antigens on your blood, and your body makes neither anti-A or anti-B antibodies, so it won't do anything with either of those. So you could receive A, you could receive B, you could receive O. And you could be type O. Type O has neither A nor B on its surface, yet they create anti-A and anti-B antibodies. So type O's can only receive O's. They can't receive A or B. However, type O can be given to anybody because they don't have those antigens to do battle with the antibodies that person already has. So type O's can give to anybody, or are known as the universal donor. Type ABs are known as the universal recipient, because you can give them A and they're okay, you can give them B and they're okay, you can give them O and they're okay. So the universal recipient is type AB. Universal donor is type O. And then you can kind of see what happens in that second picture there, 656. When you have the surface antigens on there, you get that opposing antibody that comes into play, and they start to clump and causes hemolysis. And hemolysis is the breakdown or destruction of the red cells. So it bursts the red cells, essentially. Now we also have the RH factor. So RH positive, then they have RH antigens on their red blood cells, and they have no anti-RH antibodies in their blood. RH negative, they do not have the RH antigen on their red cells, and they also do not initially have anti-RH antibodies. However, if they're exposed to RH positive blood, they will develop anti-RH bodies, and this is sometimes what happens in the case of newborns. So this is why they do a lot of blood typing when a woman is pregnant. They want to make sure that the baby's blood type and the mom's blood types are compatible. And occasionally moms will get a shot called RhoGAM, which is an immunoglobulin that will help destroy any fetal RH positive red cells that enter her blood before she can produce antibodies against them. And in most cases, as long as there's no intermixing of those bloods, we don't have a problem. However, at the time of childbirth, and maybe the very first child that the mom had was RH pos and mom was RH neg, then she's already started to build some of those antibodies. So kind of can make things kind of ugly. So in transfusions, we're really looking for a couple of things. We're looking for their pos or negative of their RH, as well as their ABO system. In most cases, if we give somebody negative blood, we're pretty safe. So O neg, you'll hear them talk about O neg, get a couple units of O neg. O neg, generally people are not going to have a reaction to, because you're lacking all of the antigens and the antibodies around. So it's fairly safe to go with O neg, at least in a pinch. All right, so patients under treatment for cancer may tell you about their blood count or their CBC. Remember, I mentioned that before. CBC is the complete blood count. So that's when they're going in, the docs are going in, they're looking at things like red cells, white cells, the differential of the different types of white cells. They're looking for, of course, they're going to blood type them, which that's something different. That's actually called type and cross, and type and match. But they're probably going to look at that, particularly if they're going to be a candidate for a transfusion. And then cancer or as treatments like chemo and radiation really can cause a lot of danger to CBCs. So they watch those very closely in most of these people that have a cancer. The CBC is probably the most commonly run lab for those guys. That probably see it almost every single time they go in. They may end up on some significant changes in their medication therapy, for example, epoetin, should they have a dangerous drop there. Remember, when you're under treatment for cancer, it's very difficult to only target cancer cells. I mean, they're finding some great advances, but still, a lot of things, once it goes in, it damages all the cells. So it really knocks people, even their good healthy cells, on their butt. So the patient may also not even be aware they have an underlying hematologic problem. So we'll say excessive bleeding from a minor mechanism of injury might clue you in that they are on a medication that interferes with hemostasis. Most of us wouldn't think somebody slipping and falling in their kitchen or their living room could potentially really have a life-threatening issue from simply this fall. I mean, for heaven's sake, they fell 5 feet. But if they have difficulties with hemostasis, whether it's a medical condition or whether it is a side effect of a medication, then they can bleed to death. They can bleed inside their skull, so they would have a head injury. Could have a gastrointestinal bleed. Could have this wound that normally would be very minor, nick or slight cut, that just won't stop bleeding. And then epistaxis. Epistaxis is excessive bleeding from the injury, specifically the nose, and the hematoma formation that interfere with the airway. So epistaxis is a bloody nose. It's just a pretty way of saying it. And occasionally we see some other outward signs that people might have. So something like purpura, or sometimes also referred to as hemorrhagic purpura. We've brought up meningitis in the past. In the neurologic chapter specifically, I mentioned purpura. Purpura are these very large, dark, bloody red or bloody purple bruises, more or less, pooling of blood. Whereas petechiae, which we see on this next slide here, is a very fine rash, more or less. It's not technically a rash. What it actually is burst capillaries, and all these little itty-bitty tiny bleeds in the skin there. It comes from petechiae. Purpura, in most cases, tends to lead you down a path of an infectious disease. Petechiae may be an infectious disease, but it may be something as simple as like a crush injury, where there was excessive pressure as they held their breath, and got hit in the chest, and it causes some minor blood vessels to burst, kind of like when you get when you pop a little capillary in your eye. It's basically the same thing. All right, so as we're doing our assessment on our patients, looking for various signs and symptoms of bleeding. Some of them are obvious, some of them are not. So the GI bleed, which we're going to talk gastrointestinal this week as well. The GI bleed, in many cases, can be kind of a silent killer because you don't have a lot of outward signs that show you. So lymphadenopathy, where you have swollen lymph glands, that could potentially be another sign that there is a problem with blood. Remember, a lot of the wastes that occur in our body are transported by the lymph system. and the lymphadenopathy, where they get this swelling of the lymph glands, can be a sign of that as well. Our general treatment for these people is really going to have to be supportive in most cases for hematology, simply for the fact that we don't have a lot of things to back us up and help us out here. So it's the oxygen, some IVs, maybe some analgesia, particularly if somebody has something sickle cell anemia or sickle cell crisis can cause a ridiculously painful condition. So you could want to consider doing a little analgesia with your nitrous oxide for those folks. In general, our signs and symptoms of hematologic disorder can be kind of summed up here on this box, which you will also find on 657 in your textbook. Tachycardia, tachypnea, the body says, hey, I'm not circulating well, I'm not getting enough oxygen. Dyspnea kind of goes in with that. So all of those things can be symptoms or telltales that you have something going on. Fatigue, malaise, weakness. When the body doesn't have enough red cells, it doesn't transport enough oxygen around, makes the body wear out quite a bit quicker. Pallor, pale skin color, that should be obvious. Lymphadenopathy, so the swollen tender lymph nodes, usually up, say, around your neck, underneath your ears, and then there's some up actually in your armpits, and then in your groin are the most common places that they'll look for those. There are other places, but fever, if it's an infectious cause, or fever also is very common in a person with a transfusion reaction. Hematuria, blood in the urine. Petechiae, we talked about that. Purpura, so petechiae are pinpoint purpura. These are greater than 3 millimeters in diameter, in most cases significantly larger. Unusual bruising and bleeding. Pruritus, which is itching, abdominal pain, particularly in the liver or spleen, or it could be anywhere depending on if it's a GI bleed versus some sort of a crisis. Joint pain and swelling tends to be in the joints. You get some trapping of the various blood components, particularly, say, some platelets or sickle cells can all get caught up there and cause some swelling, cause some pain, because it's kind of a point in which blood does not always flow nice and easily through it. Syncope, or passing out. Jaundice, of course. Jaundice is the yellowing of the skin and eyes. And severe night sweats. All kind of depends on their disease process. All right, so you obtain a set of vital signs, use your monitor devices, that you look at the patient's list of medications, see if there's anything that's helpful that kind of waves your flag that you have a hematologic issue. Transfusion reaction. While this is not common for us in EMS, if your service does interfacility transports, you can run into some blood transfusion reactions from time to time. The person would have received maybe a blood transfusion at the sending facility before they're getting sent down to the tertiary facility, or occasionally even they'll give them a blood transfusion and send them back to the nursing home. But you cannot transport a patient receiving a blood transfusion. That is a paramedic only skill. So do not, if they try to send you with blood, do not take it. If it's a blood product, if it's platelets, if it's plasma, you cannot transport that. It is a potentially dangerous situation to be in. So signs or symptoms of reaction: flushing, pain at the infusion site, because all those antibodies are showing up there to fight it. Chest pain, back pain, flank pain, restlessness and anxiety, nausea, fever and chills, and renal failure, or very low urine output. So not a lot of giant red flags here. So a lot of it has to really be based off of your clinical judgment and you stopping to think about, okay, what happened, what potentially could be going on here, have they recently received a blood transfusion? And usually when this happens, it's within a couple hours at the very most. In a lot of cases, they haven't even finished the blood transfusion before this starts. Basically, just like what I mentioned. So what other problems might occur as a result? Well, remember, if the patient's having a transfusion reaction and that starts to cells start to attack other cells, we can very quickly go into some sort of a cardiovascular crisis. We can have some respiratory issues that are going on. We can have patients can have a full-blown MI. So anemia. We talked about anemia. So we're in the red blood cell disorders. Anemia is typically an abnormally low hematocrit. They become symptomatic when that hematocrit drops below 30%. So you may be saying, now what was that again? So if you take your eyes back to the bottom of the first column, 653, your typical hematocrit is somewhere around 45% of your formed elements. So remember, it was 40 to 52 in the male, 35 to 47 in the female. So when you now have so much extra fluid and so little of the solid stuff, you have an anemic issue going on. It can be as a result of decreased production of the RBCs. It can be from an increased destruction of RBCs. So remember, they live for about 120 days and then the body starts to knock them down. It could be from a loss of red blood cells or a hemorrhage. So imagine this, somebody who doesn't have enough iron, doesn't create enough hemoglobin, they're anemic. Somebody who has a GI bleed and has been bleeding every time they have one of their 20 loose stools every day, they're going to become anemic. Somebody who has been in a severe accident and has had a leg amputated has the potential to be anemic. So cells do not receive enough oxygen for energy production, so it really starts to knock that patient down, so they're not able to function. Very tired, a lot of malaise, and probably are going to be just want to take a nap all the time. So signs and symptoms of anemia: fatigue, pallor, tachycardia, shortness of breath, particularly on exertion. They maybe have enough red cells to supply them during the time in which they are sitting around doing nothing, but once they get up to go do something, they get dyspnea upon exertion. That can be as a result of that, because they don't have enough red cells to work, just have enough red cells to survive. So in severe cases, they could have chest pain or signs of heart failure, mainly in the cases in which they're really, really low or they're working really, really hard, and it really zaps the amount of blood and oxygen that's available to go to feed the heart itself. And we've kind of talked about some of the various causes, whether it's hemorrhage or whatnot, radiation and chemo, viruses, some autoimmune disorders will start to break them down. Red blood cells, bone marrow production of red blood cells gets affected, say maybe from chemo. And then in pregnancy, we see large blood volume increase in pregnancy. However, if they lose some of that, they may not be able to supply everything as needed. There's another type of anemia that gets touched on from time to time. It's called pernicious anemia. It's a genetic deficiency in the ability of the stomach lining to produce the intrinsic factor, in which case is used by it's used to help absorb vitamin B12 with the gastrointestinal tract. B12 is needed in the Krebs cycle to help create energy. And it also affects the division of red cells. So and knocks down our number of available red cells and our ability to produce those. So people who end up having weight loss surgery, where they go out and they cut out a significant chunk of their stomach, they sometimes will end up as anemic because so much of this intrinsic factor that is created in their stomach has now been taken away because that tissue no longer exists to create it. So sometimes they'll end up on some supplements for that. You can also have hemolytic anemia. Hemolytic anemia is where the blood cells start to destroy and break down much quicker than they should. And then sickle cell anemia, which we're going to get to here right now. So here we can kind of see in the middle here we have a mass of sickle cells that have kind of caught up there. And you can kind of see them represented as looking like kind of boomerang shape. Remember, they're flexible like the red cells too. So these boomerang shaped cells have more corners on them, and so they can catch each other. So if they start to catch up, then they start to cause a dam or a blockage in the vessels. And beyond that, all that tissue starts to suffer. You can have things such as mass areas of hypoxic cells. You can even end up with some inflamed, damaged, and necrotic tissue from an infarct. Remember, an infarct is death of an area of cells there. So, sickle cell disease is a genetic disorder. It is most common in people of African, Mediterranean, Middle Eastern, Caribbean, South and Central American origin or descent. So most common in them. It's not absolutely not seen anywhere else, but it's very uncommon in those. The red cells, they take this abnormal appearance and they live only 10 to 20 days as opposed to the normal 120 days. So their lifespan is extremely short in comparison. So there's a video on the sickle cell anemia. You can see right there that is a microscopic view of normal red cells as well as sickle cells. The sickle cells kind of look like little worms, more or less. Okay, so their odd shape makes it kind of difficult for them to move through the capillaries. I guess if they went through on their axis lengthwise, they actually would probably move through pretty easily, pretty nicely. However, it's when they have to try to bend in order to get through there that they become a major issue. So, and then when we have a sickle cell clump that obstructs our capillary bed, that's referred to as that vaso-occlusive crisis. So a vaso-occlusive crisis, and that causes hypoxia and can lead all the way up to an infarct. That, like I mentioned early on in the chapter, is a very painful process, a very painful time in which those people, when they have a vaso-occlusive crisis, a lot of times it will actually begin to affect their spleen, where their blood cells are kind of stored. They'll complain of bone pain from time to time because, remember, that's where the red cells are created, and significantly a number of them filing through there. Their liver can have some issues. It can cause a priapism in males, so an involuntary erection, and so very, very painful. Usually they recommend oxygenation because they're probably going to be somewhat hypoxic. Hydration, because if we put a little extra fluid in there, we might be able to expand these vessels a little bit and allow things to move through a little easier. And then analgesia. We could start with some nitrous oxide, but it would be best if this patient can receive some narcotics, so some morphine or some fentanyl to help with that pain. So a lot of people who end up with who have sickle cell disease end up eventually having a splenectomy, where they go in and take the spleen out because it just constantly gets pummeled with these vaso-occlusive crises. Additionally, these people are high risk for anything that has to do with circulation. So strokes, blindness, because the very fine blood vessels that feed the eye, leg ulcers, renal failure, MI, you name it, PE. They run a high risk for those as well. So And they will also create an excessive amount of bilirubin, and that from the hemolysis, which is the breakdown of those red cells, might cause them to have a kind of a slight jaundice to them, and tends to also lead to gallstones and cholecystitis, which is inflammation of the gallbladder. So not a fun thing. Most people will do pretty well. They pay pretty close attention. They start to feel things come on. They're seeking medical attention, keep themselves well hydrated, so on and so forth. Sometimes they're on various medications to try to help them create the normal red cells. But once they get a crisis, it's pretty common to see them have a couple crises in a row. Then they might have kind of a little bit of a remission. Oops. Leukemia. So now we've moved to the white blood cell disorders. So remember, those white cells are responsible for fighting off infectious material from our body. They also are involved with the inflammatory process. Leukemia is a cancer that causes the bone marrow to rapidly produce large numbers of white blood cells. So typically these people will have enormous white counts. So talking into the hundreds of thousands. So there are several types of leukemia, of which some are acute, some are chronic, and then there are further named for the different types that they affect. So as you look further down in the paragraph, you'll see that they have acute lymphoblastic leukemia, we have acute myelogenous leukemia, and then we can have chronic leukemia and chronic myelogenous leukemia. It's not ultimately important that we specifically look at those names, but to understand that this is usually an overload of white cells, and with that actually starts to crowd out normal cells, so it can create anemia. So if the body says I have to have 45% of my blood be solid things, and if I have all these other white cells floating around here, I don't have quite as much room for red cells. I don't have quite as much room for platelets. So I'll have to start getting rid of some of those. Also can cause some excessive bleeding because there's no platelets there. All right, common signs or symptoms that kind of go along with this: easy bruising, bone pain, because again, this is occurring where the bone is created, an enlarged spleen. Now you may be saying, now wait a minute, that was red cells. Well, the spleen is going to be enlarged as well because it's trying to crowd out some of these other cells. Not to mention the spleen not only is a blood bank, but it also is a large mass of lymphatic tissue, and the lymphatic tissue is responsible for cleaning up messes. So there could be lots of messes in there. Swollen lymph nodes, repeated infections that they just can't seem to kick, and then chronic fatigue. We transition to lymphoma. Lymphoma are cancers of the lymphocytes. That can be either the B lymphocytes or the T lymphocytes that are localized in the various lymph nodes. Lymphomas can either be Hodgkin's or non-Hodgkin's versions. Hodgkin's lymphoma is generally a very high survival rate and a relatively high for non-Hodgkin's lymphoma. So, with treatment, and of course a lot of it depends on timing too. It needs to be found early. Found early, it's generally pretty darn treatable. All right, so patients can have might complain of a history of profuse abnormal night sweats. Bring that one back up, where they truly drench the bed while they're sleeping. And this is seen really in two major instances, as they describe in the book: lymphomas and tuberculosis. Multiple myeloma. So multiple myeloma is cancer cells in the bone marrow itself, and this causes the cells to abnormally multiply, crowd out the normal cells. It results in the production of blood cells and can cause pathologic fractures of the affected bone, basically meaning that it's starting to really damage the structure of the bone and the associated parts of it. So pathologic fracture would be not a traumatic injury that's caused, but something simply as stretching your leg out could cause a pathologic fracture because it's weakened the bone that badly. Most common complaint that goes with multiple myeloma is severe lower back pain, just from people sit, and as they sit, it causes some excessive pressures that starts to damage the vertebrae. All right, so an increase in the white blood cell count is an indication of an infection, inflammation, or a blood cancer such as leukemia. An examination of the types of white cells are responsible for their increase in their stages of maturity or differential help determine the type of infection. So like we mentioned before, you may have certain types that go up with fungal, certain types go up with viral, certain types go up with bacterial, some of them with parasites. So what can cause a decrease in white blood cells? Most of the time, if things are going to cause a decrease in white blood cells, it's, well, number one, reducing any of these infections and inflammations, of course, or leukemias, fixing those above stated problems, but in many cases they're also killed off by certain medications, chemotherapies, and radiation therapies can knock off white cells as well. We have platelet disorders. Platelet disorders, say low number of platelets. That is a condition referred to as thrombocytopenia. Thrombocytes are the platelets, and then penia is a lack thereof. So platelets get reduced in number or impaired, again by leukemia or other bone marrow disorders. And an increased platelet count results in a risk for bleeding and clotting, or thrombocytosis. So we have the two extremes there. We have low, which is thrombocytopenia, or high, which is thrombocytosis. We may also be discussing something such as hemophilia. And hemophilia is generally an inherited disease. It's caused by a deficiency in certain clotting factors, and there are tons of them. I mean, if you look in the, there's 20 of them approximately, but if you look on 660 there, you see them talking about hemophilia A, which is an X chromosome defect that results in deficiency of clotting factor 8. Because females have 2 X chromosomes, they may carry one normal and one defective gene for factor 7. They can be carriers, but their blood clotting is normal. However, if a male inherits defective X chromosome, he will have hemophilia, because males have an X and a Y, females have XX. So if you have one good and one bad, you usually can kind of counterbalance. But if you only got one, that sucks. So hemophilia B is also linked to X chromosomes as an inherited disorder. It causes a deficient factor 9. You can also have issues in which clotting factors get affected from liver disease, autoimmune disorders, childbirth, vitamin K deficiency, von Willebrand's disease. Von Willebrand's disease is an inherited deficiency of von Willebrand's factor, which is important in platelet aggregation and then the breakdown of some of the clotting factors. So a lot of times these people end up on pretty significant medications to kind of help with this. Some of them will do a lot of good, and some of them just will basically have to rely on fairly frequent blood transfusions throughout their life to kind of build them back up to where they were. Hemophilia, typically they'll have painful swollen joints. Abnormal menstrual bleeding, just doesn't stop, bleeding of the gums, bruising, epistaxis, rashes, purpura, petechiae, prolonged bleeding, GI bleeds, UTIs, urinary tract bleeding, which usually comes with UTIs. But so these people have to be extra careful in cases of traumatic injury because what would be a simple injury to most of us could be a life-threatening injury to somebody with hemophilia. So blood clots and DVTs. The deep vein thrombosis, it's a blood clot that forms in a deep, large vein, usually the leg, the pelvis, or the arms. It's usually around on the periphery. If that breaks loose, it can cause a pulmonary embolism. In most cases, if it breaks loose, makes its way to the venous circulation, and then that venous circulation feeds the blood back up to the heart. But in most cases, if it gets pumped through and it makes its way through the into the heart, it then gets, remember, sent from the right side of the heart to the lungs for oxygenation, and that's usually where it finds the next smallest bottleneck in the system, and so therefore it lodges there. If it makes its way through the lungs in some way, shape, or form, there's that possibility that it could then make its way to a coronary artery and cause a MI, or make its way to the brain and cause a stroke. So, but in most cases, it's trapped and caught in the lungs, causes that section of blood vessels to occlude, and therefore causes the patient to not be able to move blood and oxygenate blood through there. A lot of times people will end up on anticoagulants, so they may be on warfarin constantly or Coumadin. IV drug users occasionally will get these. However, in many cases, those really are probably from many of the impurities that they are getting from their IV drugs. DIC, we've mentioned this before, disseminated intravascular coagulation. This is from a systemic overactivation of the clotting mechanism and cascade. So the body kind of goes into overdrive, and it's going to result typically from things such as blood transfusions or blood transfusion reactions. The body's kind of overstressed there. Sepsis, in sepsis, where the body has so many hormones and factors flooding the system, it can really put it under fire. Surgery, recent surgery, major surgery, severe trauma, childbirth. I've even seen this occur from childbirth. Somebody developed DIC after having some retained portion of their placenta. So treatment is pretty difficult. It really is going to be, they're going to look to be a shock patient. We're not going to know for sure in the field that they have DIC. That's going to be something that they're going to have to diagnose in the hospital, and then treatment becomes treat for shock and transport in a hurry, get these people to the hospital. So if there's anything that can be done, and remember, like I said, in many cases this has a fairly high mortality rate, it can be. All right. So remember, hematology is the study of blood and blood-forming organs. Blood is composed of plasma as well as the formed elements. Plasma contains mostly proteins and water, but also has the antibodies, clotting factors, electrolytes, nutrients, hormones, so on and so forth. Red cells carry oxygen and carbon dioxide bound on their hemoglobin. A decrease in red cells from blood loss can increase or increased destruction can cause hypoxia. The abnormal shape of the red sickle cells, red blood cell sickle cells, can lead to a hemolysis and microvascular occlusion. Antigens on the RBC surface are basis for blood typing, so our ABOs and our pos negs. An increase in white cells is usually a response to either infection, inflammation, or a pathologic process. Each type of white cells has a very specific function. The hemostatic process includes vasospasm, platelet aggregation, and then activation of the clotting cascade. Patients' lists of medications can give us a lot of great information about things that they're on. So having your medication guide, your medication reference handy, can give you a lot of good information. Why do you take this medication? So, abnormal localized blood clotting is referred to as DVT, which can lead to other large issues. And then finally, systemic activation of the clotting mechanisms is DIC.